I hope you're doing well. Today we are going to look at measles virus infection. Measles infection is a highly contagious viral disease and mostly affects children and rarely affects infants less than 3 months because of the passage of maternal antibodies. It's associated with serious complications and high mortality. Check out my other video for a detailed explanation of the complications of measles. So let's dive in. Mesovirus is a single-stranded negative sense lipid enveloped virus with one antigenic type. It belongs to family Paramyxovirus and genus Morbillivirus. Humans are the only reservoir. It has an incubation period of 10 to 12 days from the time of the exposure to the onset of symptoms. It's transmitted typically by respiratory droplets, direct contact, or fomites from uninfected individuals. Infants less than 1 year rarely acquire measles due to the passage of maternal antibodies, like I've mentioned before. Face-to-face contact is not necessary for you to get infection because the viable virus may be suspended in the air for as long as 1 hour after the patient with the source case leaves the room. The pathogenesis of measles is divided into 4 phases: the incubation period, prodromal phase, eruptive phase, and then recovery or convalescent phase. In the incubation period, we are going to look at 3 major events. The first one is initial invasion, which involves the measles virus entering the respiratory tract, infecting the epithelial cells, and then migrating to a nearby lymph nodes. It replicates from there and infects lymphocytes. Then in primary viremia and spread, the infected lymphocytes carry the virus. Carrying the virus enter the bloodstream. As they move, it allows the spread of this virus from one organ to another. And then in the secondary viremia, this is where there is now spread of the virus to the body surfaces like the skin, and it will be manifested as a rash. Therefore, in prodromal phase, it follows secondary viremia. It's associated with the appearance of symptoms which typically include the fever, malaise, anorexia, and followed by inflammation of the conjunctiva. Of course, inflammation of the conjunctiva varies from the extent varies from one individual to another. Then you have coryza and cough. The respiratory tract infection that we have seen, like the cough, are due to mucosal inflammation from the virus infection of the epithelial cells. Prodromal phase begins after secondary viremia and is associated with epithelial necrosis and yarn cell formation on the body tissues. Also, this phase is where virus shedding begins. This phase lasts 2 to 3 days, but in some individuals may be prolonged up to 8 days. So in the in the third phase, which is eruptive phase, this starts on day 5 or day 4 of the illness when fever rises. It's characterized by the maculopapular blanching rash on the face and spreading in a certain pattern, that is cephalocardial pattern. It involves it being spread from the face and then it comes to the trunk, upper trunk, lower trunk, and finally the extremity. This rash may also have some petechiae and may appear hemorrhagic. So we have two pictures here. This picture is showing the maculopular rash that appear during the eruptive phase. And then this picture here is showing the progression of this rash. So the left side here shows the early rash. I think the rash covering the head and the upper part of the body. And then this picture, this side here, it shows now later covering the whole body. And then another feature that we should note is the Kipling spots on the buccal mucosa, which are described as grains of salt on a red background, as indicated in this picture here. This is a red background and you have this whitish Kipling spots. These spots generally appear 1 to 2 days before the rash. They are pathognomic for measles but not always present. Should also note that the palms and the sole are spared. Other features of this phase include lymphadenopathy, high fever which peaks 2 to 3 days after the appearance of the rash, respiratory signs including pharyngitis, and then non-purulent inflammation of the conjunctiva, and then hyperpigmented skin lesions may persist long after the active measles infection. This will act as an evidence of post-measles infection. Then finally, we have the recovery phase or the convalescent phase. Here, cough may persist for 1 to 2 weeks after the measles infection, and the occurrence of fever beyond the 3rd to 4th day of the rash suggests a measles-associated complication, meaning by 4th day from the time of the appearance of the rash, the fever should be decreasing. And then, immunity after measles is thought to be lifelong, although there are rare reports of measles reinfection. So let's look at what makes an individual more susceptible to measles infection. One, children with immune compromise due to HIV, leukemia, or corticosteroid therapy, regardless of their immunity, immunization status. Then travel to areas where measles is endemic or contact with an individual from endemic area. Infants who lose passive antibody from they lose these passive antibodies that were received from the mother before the routine age of immunization. And then also there are those factors that expose you to getting severe measles and the complications of measles. This includes malnutrition, underlying immune deficiency, vitamin A deficiency, also in individuals of extreme age whose immunity is not very developed. Let's contrast between severe measles and non-severe measles. So a child can get measles and these measles can progress and qualify to be very severe basing on the following features. If the child has evidence of measles with any of the following signs and symptoms. One, inability to drink or breastfeed, vomits everything that takes, and then is having episodes of convulsions. On examination, look for signs of complications of measles, which include lethargy, unconsciousness, corneal clouding, corneal ulceration, deep or extensive mouth ulcer, pneumonia, dehydration from diarrhea, and severe malnutrition, and stridor due to misochrome. Then severe measles will be diagnosed in a child whose mother clearly reports that the child had a measles rash, or if the child has the following: fever and generalized rash, and one of the following features: cough, runny nose, or red eyes with no clinical features of severe measles. So how do you diagnose? Basically, diagnosis of measles is based on clinical and epidemiologic findings. There is a triad of cough, coryza, and inflammation of the conjunctiva. Then you have Kipling spots, and then the cephalocardial progression of mebiliform erythema. This is very important. That rash, the maculopapular rash, has this pattern of progression. Then the post-measles desquamation and hyperpigmentation. In this way, you're trying to find out whether this person actually had measles before. And then also there are some lab findings that can help you to rule out different differentials and guide your diagnosis. For example, on CBC, you may see leukopenia and relative lymphocytosis and thrombocytopenia during measles infection. And then you can confirm by serology. This is going to be based on identification of measles-related IgM and IgG antibodies in the blood serum. Then you can also use PCR, which is very effective in confirmation of measles. And then viral culture, rarely done. Then biopsy samples of lymphoid tissue before the appearance of the maculopapular rash may demonstrate reticuloendothelial giant cells. And then a liver function test can be done, and the transaminase levels will be elevated in measles hepatitis if it has gone and affected the liver cells. And then if it has affected the meninges, a lumbar puncture can be done, and the CSF will reveal increased proteins, normal blood glucose, and then mild pleocytosis with lymphocyte predominancy. Then mostly the markers of inflammation, this is the ESR and C-reactive proteins, they are normal unless it's complicated by bacterial infection. So how do we treat these patients who have measles? Since it's a virus infection, we are going to concentrate on supportive therapy and boost the immune system. So our goals will include maintenance of hydration, oxygenation, and comfort. Shall give antipyretics for the control of fever. We shall also give airway humidification and supplementation of oxygen, including ventilation support to those patients who have respiratory tract involvement. And the antibiotics, they are indicated in the superadded bacterial infection, but normally they aren't indicated. Then antiviral therapy is not effective in otherwise normal healthy individuals. And then you can give vitamin A supplements. So vitamin A can be given in that dose for those age groups. And then we can also give this antivirus, ribavirin, can also be given for the treatment of measles. Then for post-exposure prophylaxis, we give immune globulins. They can be given for up to 6 days after the exposure to prevent or modify the infection. And then immunoglobulin is also indicated for susceptible household contacts of the measles patients. Who are these susceptible household contacts? They include infants 6 to 12 months of age, infants less than 6 months of age. If the mother without measles immunity, then also if the mother is pregnant, and finally immune compromised individuals, they should be given this post-exposure prophylaxis. And then how do we prevent the spread of this infection? You have to isolate the patient during its effective period because it's highly contagious. Patients shed measles virus from day 7 after the exposure to around 4 to 6 days after the onset of the rash. Then, therefore, in the hospital setting, standard and airborne precautions should be observed for this period. This includes wearing masks as we are going to treat this patient, and then immune compromised patients with measles shed off the virus during the whole period of illness. So isolation should be maintained throughout the disease. Then measles vaccine can also be given within 72 hours of the exposure. Wow, thank you. I hope you've learned something. I hope you enjoy it. In case you do enjoy, hit the subscribe button, hit the like button. Thank you. These are our differentials: Kawasaki disease, German measles, EB virus, EBV virus infection, scarlet fever, syphilis, rosella, mycoplasma pneumoniae, and group A streptococcal may also produce rash similar to those of measles. Thank you. Meet you in the next lecture.